عفواً أتمنى من الحضور الكرام وضع الهواتف النقالة على الصامت رجاءً. شكراً. بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف خلق الله والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. السيد دكتور قيس الدويري، الوكيل المساعد لشؤون الصحة العامة، ضيوفنا الكرام، نرحب بكم بافتتاح مؤتمر التغذية والصحة الثاني تحت رعاية معالي وزير الصحة الدكتور علي سعد العبيدي. تعتبر السمنة مشكلة عالمية تعاني منها مختلف الفئات العمرية في المجتمع بشكل عام، والمشكلة الصحية الأولى في المجتمع الكويتي بشكل خاص. الصحة واهتمامها منها للحصول على برامج وقائية وعلاجية مناسبة وفعالة للبحث على حلول لهذه المشكلة. تعقد مثل هذه المؤتمرات المهمة والمفيدة تحت إشراف العديد من المتخصصين في هذا المجال. والآن مع كلمة الدكتور قيس الدويري، فليتفضل.
بسم الله الرحمن الرحيم، والصلاة والسلام على رسولنا الكريم. الأخوة والأخوات الأعزاء الحضور الكرام، السلام عليكم ورحمة الله وبركاته. يسرني الترحيب بكم اليوم بمناسبة افتتاح مؤتمر التغذية والصحة الثاني بالإنابة عن معالي وزير الصحة الدكتور علي سعد العبيدي، وننقل تحيات وتمنيات معاليه لكم بنجاح المؤتمر وتحقيقه الأهداف المرجوة من عقده. كما يسرني الترحيب بضيوفنا الكرام من الدول الشقيقة والصديقة، متمنيا لكم طيب الإقامة ببلدهم الثاني الكويت. الأخوة والأخوات الحضور الكرام، لا يخفى علينا جميعا بأن السمنة أصبحت إحدى أهم التحديات الصحية التنموية على جميع المستويات الوطنية والإقليمية والعالمية. فخلال العام 30 الماضية تضاعفت معدلات الإصابة بالسمنة، لتمثل عبئا صحيا واجتماعيا واقتصاديا لكثير من دول العالم، فهي أحد العوامل الأساسية التي أدت إلى انتشار الإصابة بالأمراض المزمنة مثل أمراض القلب والشرايين ومرض السكر النوع الثاني والعديد من أنواع السرطان. وقد استوجب ذلك الإصدار الإعلامي الصحي لجمعية العامة للأمم المتحدة المنعقد في سبتمبر 2011 بمدينة نيويورك، والذي ينص على ضرورة الالتزام دول العالم بموقف جاد لمكافحة الأمراض المزمنة غير السارية ضمن برامج الصحة والتنمية لكل دولة. كما أوصت منظمة الصحة العالمية جميع الدول بتبني استراتيجيات ووضع برامج مشاريع الحد من انتشار هذه الأمراض. واستشعارا من دولة الكويت بخطورة هذا المرض، فقد تم تشكيل لجنة عليا لمكافحة الأمراض المزمنة غير السارية تضم ممثلين من جميع الهيئات والمؤسسات الحكومية والأهلية وجمعيات المجتمع المدني، وذلك لوضع الاستراتيجية العلمية والملائمة للحد من انتشار عوامل اختطار الأمراض المزمنة، والتي تعتبر السمنة من أهمها. كما تم تشكيل العديد من اللجان وفرق العمل الأخرى لتنفيذ توصيات اللجنة العليا من إجراء الدراسات والبحوث والتقييم والبرامج التوعوية. الأخوة والأخوات الحضور الكرام، إن المحاور التي سيتناولها المتحدثون خلال فعاليات المؤتمر تأتي بنفس الإطار الذي وضعته وزارة الصحة، والذي يهدف إلى التعرف على الوضع الحالي والوقوف على أحدث المستجدات العلمية والعملية المتعلقة بعوامل انتشار السمنة والسلوكيات الغذائية الخاطئة المكتسبة نتيجة المدنية الحديثة والآثار النفسية والجسدية الناتجة عن السمنة، وكذلك أساليب الوقاية والعلاج سواء بالتدخل الجراحي أو اتباع السلوكيات الغذائية الصحية وممارسة الأنشطة الرياضية. هذا بالإضافة لما ستثريه فعاليات المؤتمر من تبادل الخبرات والمعلومات العلمية والطبية في هذا المجال. وأخيرا أود أن أتقدم بالشكر الجزيل للجنة المنظمة للمؤتمر على جهودهما الملموسة في تنظيم المؤتمر، وكذلك ضيوفنا الكرام على حضورهم ومساهماتهم الفاعلة. راجل الله لكم التوفيق والسداد. والسلام عليكم ورحمة الله وبركاته.
كل الشكر للدكتور قيس الدويري. والآن مع الدكتورة AL-HAMAD، مدير إدارة التغذية في وزارة الصحة، لإلقاء محاضرة بعنوان السمنة في دولة الكويت، فلتتفضل.
Good morning, ladies and gentlemen. I would like to welcome our guests and visitors, those coming from abroad. I hope you had a safe journey. I hope you will enjoy the conference with us this morning and the next few days, because we will definitely enjoy your presence, your company, and will benefit from the lectures that you will present to us. be about obesity in Kuwait, facts and challenges. I'll talk a bit about obesity at the beginning. We all know that it's a worldwide epidemic and it's been attracting attention at the international and national levels because of its effects on health, the enormous economic burden that it imposes, and its increasing prevalence. We also know that overweight and obesity are the fifth leading risks for global deaths. At least 2.8 million adults die each year as a result of being overweight or obese. And according to the latest WHO report, 44% of the diabetes burden, 23% of the ischemic heart disease burden, and between 7 and 40% of the certain cancer burdens are attributable to overweight and obesity. What is overweight and obesity? It is excessive or abnormal fat accumulation that impairs health. Body mass index is a very useful and clinical and simple tool for an index for weight for height, and it is commonly used in the practical setup to classify overweight and obesity. It is defined as weight over height squared, and according to WHO definition, if you're 25 or above, you are overweight, and if you're 30 or above, you're obese. Raised BMI is very serious because it is a risk factor for diseases such as cardiovascular disease, diabetes type 2, musculoskeletal disorders, and some cancers such as endometrial, breast, and colon. And as we know, as BMI increases, the risk for non-communicable diseases also increase. Childhood obesity is a big problem because the effect carries on as they go into adulthood, and so premature death and disability in adulthood is known. Because of all this, the United Nations General Assembly adopted the Political Declaration of NCDs in September 2011, and consequent to that, WHO developed a global monitoring framework to enable the global tracking of progress in preventing and controlling major NCDs. And these are cardiovascular disease, cancer, chronic lung diseases, and diabetes, and especially their key risk factors. The framework consists of 9 global targets and 25 indicators. It was adopted by the member states during the WHA meeting in May 2013, and hence member states are urged to develop national NCD targets and indicators building on the global framework that was developed. The aim is to combat global mortality from the 4 main NCDs, to accelerate action against the leading risk factors for NCDs, and to strengthen national health system responses. The mortality target, which is a 25% reduction in premature mortality from NCDs by 2025, has already been adopted by World Health Assembly in May 2012. This is the famous poster that was developed by WHO, showing in black circle the premature mortality reduction by 25%. The blue circles are risk factors, and the 2 pink circles are the national health responses. The global network framework is also asked by the countries all over the world or member states to identify these factors and work on plans and of actions to control them. As we know, when we said that obesity is related to mortality, so a lot of research was done to assess obesity and life expectancy and to measure the years of life lost. And this is one of such studies that was published in 2003, showing the number or measuring the years of life lost at the age of 40, and showing that if you are overweight and obese, for males and females, and they are non-smokers, they lose 3 years of their life, and if they're obese, 7 years and 6 years respectively. Now, if you're a smoker, these figures automatically double. Another study, which was done more recently, and it was published in The Lancet in March 2009, is the Prospective Studies Collaboration Meta-Analysis, and it's the data collected from 57 long-term cohort studies from the US, from Australia, and the European Union, and the participants were 900,000 participants. They were followed for 10 to 15 years, during which 100,000 died. And they had inclusion and exclusion criteria, but at the end, the results were similar. Here, they assessed the years of life lost at the age of 60, and it showed that the lowest mortality for both sexes was if your BMI was between 22.5 and 25, which is the normal range. If you go above that, class 1 obesity, you lose 2 to 4 years of your life, and if you're above that, it's 8 to 10 years lost. The effect is much greater if you are a smoker, and for each 5 kilogram per meter squared increase in BMI, there's higher overall mortality by 30%. This is a presentation of the prevalence of obesity in the countries of the region, showing that Lebanon, this is by WHO in 2010, Lebanon has the lowest, whereas Saudi Arabia has the highest, showing that Kuwait is almost 30% prevalence of obesity. Now in Kuwait has experienced since the early 60s and with the discovery of oil and the transition in the economy of the country and the increase in the standards of life, significant economic changes. From a public health perspective, the government prioritized its spending policies. It introduced immunization programs because its target was to improve the health of the nation. It established health centers, focused on providing and making available medical staff, the whole team, the medications, focused on special age groups, mothers and child care. And so in the end, the consequently rates of mortality and morbidity from infectious diseases significantly dropped. There were marked improvements in other sectors, schooling and education, social welfare and income. Food policies were introduced, so foods can be available all year round with affordable prices. And they also introduced food subsidies. And so over the years, like many countries in the world, people's lifestyles and eating habits were hugely affected. You know, the replacement of our own traditional foods with trendy foods, fast foods. Even our own recipes were modified and now they contain more saturated fats, more sugar, all with the intention of bringing in new ideas. Technology, of course, promoting and inducing sedentary lifestyle, and also help in the homes and at work. All these are special to Kuwait and maybe in the Gulf region where it's more promoting to sedentary lifestyle. So Kuwait is still is in the economic transition where reduced morbidity and mortality of infectious diseases, but we are facing the challenges of increasing trends in NCDs. I would like to show you this slide, and it's with the permission of Professor Longenecker in the medical school. He's an epidemiologist. This is an initiative called Kuwait in Energy Balance, and it's by a group of researchers started in the Kuwait Institute for Scientific Research. Now the members have increased. We are from Kuwait University, they are from Kuwait University, the nutrition department, from medical school, departments of epidemiology, community medicine, from obstetrics and gynecology, diabetes, from neonatology and pediatrics, and also from Ministry of Health. All these specializations are also from Ministry of Health, including the Department of Primary Health Care and Nutrition. It also includes medical school, genetics, and the whole idea is these researchers are concerned with the research-oriented plans of action and strategies to support the Ministry of Health. The Ministry of Health is going with the strategies recommended by WHO to have our targets that we just mentioned and indicators. The Kuwait in energy balance, called KIAB for short, are trying to back up and support and fill in the gaps with the Ministry of Health so that we can reach our targets, but with accurate data and more strengthened, and we will have also health economists because we want to have our best buys. So we're asking several questions. The first one is where we are now. I'm showing you the data from the Kuwait Nutrition Surveillance System, and this is a monitoring system by WHO and CDC from the National Nutrition Survey of Kuwait with KISR and the AL-HAMAD project, which this is the data from 2008, but we are at the moment as we speak, it's starting again because it's a monitoring system every 5 years. This is the prevalence of obesity among Kuwaiti children 5 to 10 years from the Kuwait Nutrition Surveillance System, showing for over the 10 years that the prevalence or the trend has increased, but it seems to be stabilizing for females, and this is obesity, not overweight, obesity at 70%, and for the boys it is from 16 to 20%. And research-oriented, the key initiative that we're talking about, for example, they have suggested, and actually in the ethical committee in the Ministry of Health, there is a paper to be approved where we're looking at the early life nutrition, where is exclusive breastfeeding affecting the body composition of newborns compared to the normal or the trendy or what mothers are giving to their children, the breastfeeding or mixed feeding. We are seeing the effect of breastfeeding on the body composition, and this is with collaboration with the International Atomic Energy Agency, providing us with a novel technique, and it's called the PPOD. So such studies will help understand the situation better and maybe provide the appropriate intervention. Prevalence of obesity among adolescents, this is a very important age group, and again showing the trends, this is from surveillance system, that it is 29 to 28 up to 2010. I would like to excuse me please for the 34% in the 2012 data. We are reviewing this number because we think there could be an error, because jumping from 28% to 34, it doesn't just, can't understand, it doesn't make sense. But at the end of the day, the prevalences are high. And another study that is at the ethical committee is looking at the energy expenditure using stable isotopes, again with collaboration with the International Atomic Agency. And this is again data that are very important, physical activity or inactivity in this age group, which is contributing to the obesity that we are suffering from. The adults, of course, with the data that we have for children and the adolescents, no wonder, and we're not surprised, we have such figures for the adults. Again, 40% for females and 32 or 35% for males. Is this what because the WHO are recommending in their targets to stabilize overweight and obesity. Are we stabilized here, or do we need, from the CAVE that we are talking about, the group that are working, need to reevaluate this, assess it, make sure that it is right? Then if we are stabilizing, what is the next step to do? Or if not, what should we do? It's not enough to show obesity, we should show overweight also. This is maybe a little bit confusing, but for males and females, there are more overweight men than women. So we have more obese women than men. And at the end of the day, they're both obesity and overweight and obesity is around 70% in Kuwait. Of those who are obese adults, 21% have high blood glucose compared to the females, 13%. Regarding high cholesterol, among obese adults, we have 42, almost the same, 42 and 44% respectively for male and female. Now, what are the contributors? It's energy balance for obesity, overweight and obesity. So, caloric intake, and this is from the Nutrition Survey of 2008, showing that these figures, 2,280 for males and 1,700 for females. I think this is a very underestimate and very humble, impossible. That cannot be true. So this is maybe one of the things that we need to again assess, because it doesn't make sense with the obesity that we have, that these are the calories that they're taking per day. Not only that, we need to look into, because as a nation we eat a lot out in the restaurants. It's not difficult to go to restaurants, and even easier to order it and to come home. So we need to know the components of the diet that we eat, the fizzy drinks, the components, the saturated fat, the salt, the sugar. Recently, the BBC or the WHO restated or recommended the 10% sugar intake out of the total calories. Now, it seems to be, from reading the reports, it's very challenging. I heard it from Francisco, from WHO Director of Nutrition, and I heard it from other resources saying that it is too much. What should we do in Kuwait? Is it possible? This is where the role of the food industry is very important, and the commitment of the politicians in the government. So, does it make sense? We have to look into that. Physical inactivity or activity. 46% of the males and 29% of females indulge in moderate to strenuous physical activity. Is it true? Because we know with food intake, there's always an underestimate, and physical activity, there is an overestimate. So, is this true? Do we need to do more research to make sure that this is the right data that we have? We have to see this. The data we have here doesn't include those who are under the 20 years of age. This is why we say Ministry of Education is very important to include such curricula into their curriculum, because it is very important to, put this into the minds of our young people so that it becomes a habit. This is another important risk factor that is within the 25 indicators that we need to assess and find solutions to: fruit and vegetable consumption. It's coming from different sources: the Pure Study of 2005, from the IMAN Project 2008, from the Kuwait Nutrition Surveillance System of 2012. Contradicting data, some saying we are meeting the requirements, some are not, so we need to do it again and improve the dietary habits. That's why in the project I'm going to mention in a while about school meals, we try to introduce fruits and vegetables into the school meals and in the canteens to help improve the dietary habits. Where do we want to be? Again, this sketch is showing that the research group should choose some specific MRO targets to study, as to many MRO targets have been developed, and this is facing the WHO, facing the Ministry of Health, what to do and how to do it, and the research group can help in that. So What has been achieved so far? We need to meet the WHO targets, as I said, in a way that is adaptable to our current situation. It is mentioned in the EMRO region that we need to stabilize our overweight and obesity in children and stabilize overweight and obesity among the adult population. Another recommendation was to do exclusive breastfeeding, to increase the rates of exclusive breastfeeding in the region. But we look at overweight and obesity. Again, the question is, are we stabilizing or do we need to do more? I think we should wait for 2 years or 3 years with the surveillance system, and when the result of the AL-HAMAD project comes out, we'll be more safer to say we are stabilizing or not. It is how to reduce overweight and obesity. It's a responsibility, as we know. This is mentioned everywhere at the individual level, at the community and society level, policy making and decision making, and of course the role of the food industry. With regard to Ministry of Health, the High Committee for Health Promotion in 2004, when the DPAS strategy came out, it was established, and under its umbrella, of course it was chaired by the Minister of Health, under umbrella was the obesity prevention strategy, diabetes treatment and prevention, cancer, healthy cities, and so on. But it was reviewed and the committees re-established after 2008. But the most important now is, and after the political declaration in the United Nations, the High Committee for the Prevention and Control of NCDs, again, it was established in 2012. It's a high committee, it's chaired by the Minister of Health, and its members include the Undersecretary and other assistant undersecretaries, and many other related sectors in the country. What actions have been taken? As I said, although the other committees or strategies were re-established or reviewed, we continued, the actions were sustained. So we targeted school children, and the first thing we did with the Ministry of Education, thankfully, working together, we introduced the school meals, and we tried to provide reasonably healthy meals, meeting the daily requirements, 25% of the calories, for example, and some new ideas about fruits and vegetables, making it tempting for the child to pick it up and eat it. It's been 2009, success in some ways, but it is being reviewed at the moment to improve it. Also the canteens, the special committee for the canteens, again, to have the idea of selling the appropriate food items to pass on the message not only to the children, but to their parents and to administrators in the schools. Of course, we also introduced the Facts of Life for Life, which is a UNICEF project. It was very successful in Oman. We included it for the past 3 years. It's been very successful. But we would like to, we're hoping to see, is that applied nutrition and physical education to be part of the curriculum in the Ministry of Education. It's very challenging, but we're working on it. Actions taking, of course, other things regarding the community, because government, the private sector, the civil societies and NGOs are all with us trying to reach the appropriate, or by through the appropriate strategies to reach our goals. Health promotion campaigns, awareness, it's going on all the time. Very challenging with the TV because there are a lot of private channels that we cannot control, but the social media also now reaching our target, who are the teenagers, with the Facebook and Instagram, putting in the ideas. Regulations with foods. Now, it's very important about the food standard specifications. All the time we're talking about educating, but I think it works better if we impose it as regulations without the people knowing about it, so that it's lower in salt, lower in sugar, gradual, without the people knowing about it. And going hand in hand with research, monitoring, and evaluating this impact. Food standards and specifications, as I said, are very important. At the moment, we are looking into trans fatty acids elimination in the Gulf Standards Committee. Also, food labeling, advertising. Maybe it's all there, but we need to activate it and make sure that it is being done. Advertising is a big issue. Policy for food subsidies. Dr. Qais knows that we are struggling a lot about the food subsidies. We're trying our best to improve the system, but it's very political, as you all know. Political stability and commitment, it's a must. If we want to go from A to B, we need their commitment, not only financially, but politically, to make sure that we reach our targets. This is just a small slide with the permission from Dr. Salman Al-Sabah. He's a surgeon in Amelia Hospital. Just to show you the quick fixes that the young people are trying to do because they can lose weight easily. In their mind, they want to look well, but they're not thinking about the quality or nutrition status of their health over the long period of time. From 2007, it was 529. 2012, it's more than 10 times the number of surgeries for bariatric surgery. Most of it is the sleeve technique. And I was looking at the region. I think globally the number of surgeries are increased. In the region, it jumped from 4,000 to 24,000 surgeries with regard to bariatric surgery. This we need to look at. We need to assess the situation and make sure to ensure that those people who are under the knives and they do these surgeries, that they are meeting their requirements. It's all in tablet form and in supplements. All of us don't take a tablet. We cannot wait for it for the course of the antibiotic or whatever to finish. Can you imagine if they take it for life? Several types of tablets and supplements to improve their health. So we come to the question, how will we get there? The Ministry of Health needs to answer this question. What factors are important in the trend? What are the obstacles to reversing the trend? And what interventions work in Kuwait? So with regard to the research group, once the embryo targets are chosen, then our group or the research group should design studies to identify community and behavioral factors that play a role, develop and test interventions to change these factors, because at the end the goal is to answer some of these questions, inform the Ministry of Health and other public health entities of results, and assist in its implementation. Because then, how do we know we have reached our goals? It's by monitoring and evaluating the systems that already exist. The Kuwait Nutrition Surveillance System and the AL-HAMAD project that is done yearly, with continuing capacity building. I hope I haven't bored you, and this is the end of my slide. Thank you so much.
نشكر الدكتورة نوال الحمد، والآن يتفضل الدكتور قيس الدويري لافتتاح المعرض. كل الشكر لحضوركم وحسن استماعكم.
My name is Ross Anderson. I'm here from McGill University in Montreal and will be co-chairing this session. To start the meeting off, we have two very distinguished presenters for you for the first two talks of the lecture. The first one will deal with the global obesity epidemic that we're all aware of, and our second talk will focus more on pediatric obesity. Our first speaker today is Dr. Philip James, who really needs no introduction. He was trained in science and medicine in the UK, and he has really become very influential in looking at the global burden of obesity around the world. He has organized he established and chaired the International Obesity Task Force, and he is now the chief advisor on nutritional aspects of public health initiatives for the World Health Organization in the Middle East and Europe, covering 75 countries. Please join me with a warm welcome for Dr. Philip James.
Thank you. It's good to be back. I've been given